Okay. Thank you for inviting me to BDECO, and good evening, everybody. I'm going to present an interesting case in this session, and where an abnormal Doppler signal was a clue to the diagnosis. My patient, 55 years old male, smoker, non-diabetic, with history of long-standing hypertension, which was under control, presented to us with one episode of syncope for 15 days back. And he started having atypical chest pain in for last 7 days. His ECG showed changes of left ventricular hypertrophy, as you can see, deep S wave here, and T wave inversion. And when I did the echocardiography, in the parasternal long axis view, I got enlarged LA. But if you look at the interventricular septum, the basal part of the septum is not much hypertrophied. However, the mid-anterior septum showed some hypertrophy. There was no regional wall motion abnormality in this view. Then I went to the parasternal long axis with color flow, but I couldn't see any turbulence in the LV outflow tract. And M mode at the level of the tip of the mitral valve leaflets did not show any evidence of systolic anterior motion of the mitral valve, which we get in case of hypertrophic cardiomyopathy with obstruction to the LV outflow tract. Then I went to see the wall motion abnormality. I really did not see any evidence of any type of wall motion abnormality. All the segments were contracting normally at all the levels in short axis, as well as in the fourth chamber and parasternal long axis. If you look at the fourth chamber view, there I could see some hypertrophy, but not much. But if you look at the lateral wall, at this midpoint, there is some hypertrophy. So LV doesn't really show much of hypertrophic cardiomyopathy-like picture. However, as I put the color flow, I could see a turbulent flow across the mid cavity. So that part of the lateral wall and that hypertrophic part of the mid septum must have caused the obstruction with turbulent flow. And as I did the CW Doppler, I got the signal like this. So I started taking the pressure gradient across this turbulent flow. As I was taking the gradient, I was a bit confused because there were two signals. One is this, another is this. This one is having higher than centimeter already. Now, if I look carefully, if I look at this picture where I have increased the sweep speed to 150 millimeter per second to appreciate better the diastole and the systole, what I see that this first signal is in systole. However, the second signal was more in the early diastole. See, it's spilling over the early diastolic phase. If we look at the hypertrophic cardiomyopathy with obstruction in the LV outflow tract, this is a different patient. And if you look at the signal of obstruction, CW signal of the LVOT obstruction, which is a dagger-shaped signal, and that gradient of 112 millimeter of mercury is entirely in systole. Look in the ECG, this is the end of T wave, and whatever obstruction this patient had, it's in the signal is entirely in the systole. But in my patient, if you look, the first signal is in systole, but the second signal was in early diastole. So what is this signal? This signal is very, very fascinating. This is an abnormal Doppler signal during the early diastole in hypertrophic cardiomyopathy with mid-cavity obstruction. And this was first described by Nakamura and his colleagues, and it is a clue for concealed apical aneurysm. In classic apical 4-chamber or in the 2-chamber, I did not get any evidence of apical aneurysm. So I thought I must have missed it. Let me see properly. As I did the 4-chamber again, no, I didn't get any evidence of the aneurysm. So what I did, I tilted the probe a bit. This view is not looking like foreshortened, but still I could not get the evidence of aneurysm. So I tilted the probe a bit. The aneurysm started appearing, as you can see. And as I tilted it further, there was a clear picture of aneurysm. As you can see, it's very well visualized now. And so also in the apical 2-chamber view, you see there is a aneurysm and right at the apex, and which I have missed. And I could pick up this aneurysm only because I got an abnormal diastolic flow in the CW Doppler across the LV mid cavity. So as the patient presented, young patient, smoker, diabetic, presented with history of atypical chest pain. So we did a coronary angiogram. Both the left coronary system and the right coronary system were normal. So what is these then? This aneurysm is not a post-myocardial infarction aneurysm. The mechanism of formation of this aneurysm is very fascinating. If we look here, you see on either side of the obstruction, there are two adjacent cavities. One proximal cavity and the other one is distal cavity. Now this proximal cavity is a low pressure zone and the distal cavity develops a high pressure zone. Now this persistent high diastolic pressure in the distal cavity reduces the subendocardial perfusion, and that leads to chronic ischemia and ultimately resulting in necrosis and aneurysm formation of the apex. And you see, out of all varieties of hypertrophic cardiomyopathy, this apical aneurysm in hypertrophic cardiomyopathy with mid-cavity obstruction is a very unusual phenotype, occurring only in 1 to 2% of the cases. And this aneurysm is always under-recognized. It needs a very high index of suspicion. And whenever we get a mid-cavity obstruction, we must look for the clue in the CW Doppler signal, where we might get a diastolic signal, abnormal signal during the early diastole, which is a clue to the presence of aneurysm in this type of cases. And the mechanism of paradoxical flow also is similarly interesting, since there are two cavities, adjacent cavities on either side of the obstruction, proximal cavity being of low pressure, the distal cavity with a high pressure moves the blood to the lower pressure proximal cavity away from it during early diastole. And that gives rise to this second diastolic wave in the phase of early diastole. So, which is a clue towards the diagnosis of a concealed aneurysm. Now, this visualization of the aneurysm by transthoracic echo is challenging. As you have seen, I have missed it initially because of the abnormal Doppler signal. I tried and ultimately I got it. So foreshortening of the apex is a problem, and if we use the myocardial contrast, it will opacify the aneurysm and the diagnosis becomes easier. However, it is the cardiac MRI which can pick up the aneurysm very well, and there lies the value of multimodality imaging, and the MRI is never going to miss this type of aneurysm. And why this the identification of this aneurysm is so important? Because this type of patient is a high risk subgroup, because in the aneurysm there is stasis of the blood, so there is chance of formation of the thrombus in this aneurysm, and giving rise to the thromboembolic event and even sudden cardiac death. And also the junction of the healthy myocardium and the scarred myocardium is a site of re-entry circuit formation, leading to the ventricular tachycardia and sudden cardiac death. So if we can identify the abnormal signal and the aneurysm, we can prevent this type of complications in this hypertrophic typical hypertrophic cardiomyopathy with mid-cavity obstruction and LV apical aneurysm. We can prevent with ICD or radiofrequency ablation, and we can start anticoagulation. A study has been done, and that has been published in JACC in 2017 on hypertrophic cardiomyopathy with left ventricular apical aneurysm, where they have done a comparative study of the clinical outcome in hypertrophic cardiomyopathy patients with and without apical aneurysm. And what they found, that hypertrophic cardiomyopathy related adverse events, including the mortality, arrhythmic event, heart failure event, and also the thromboembolic events, are much higher in the patients with aneurysm than without aneurysm. So to conclude, I would say it's this type of patient of hypertrophic cardiomyopathy with left ventricular mid-cavity obstruction and apical aneurysm is really a very rare entity and a potential for underdiagnosis and underdetection. So we need to have a high index of suspicion. So whenever we get a case of obstruction, we must look for the apical aneurysm, though it is not post-MI, but because of the aneurysm, there is a chance of various type of complications, including the thromboembolism and VT. So we should have a very high index of suspicion, and always we can take the help of abnormal Doppler signal from the CW Doppler. Thank you.